Hello, my name is Logan Abel, and I'm coming from the Warren Alpert Medical School, and it's good to be with you today. I'll be presenting on the impacts of oral antimalarial medications on mortality among patients with Ebola virus disease. This is a multi-site cohort study, and the authors can be seen at the bottom. Now, in terms of disclosures, funding for this study was provided by 2 grants from the National Institutes of Health. And jumping right in, Ebola virus disease is a disease that's had multiple significant outbreaks since it was first discovered in the 1970s. Now, in particular, the data from the study comes from the 2013 to 2016 outbreak, which infected some 28,000 or so and killed many thousands of people. In general, Ebola virus disease has a very high mortality, often around 50%, but this varies significantly depending on many factors, but perhaps resources in each setting is a very large factor. Also, in many of these areas, malaria is often endemic in areas that have Ebola virus disease outbreaks. And important to this is that, especially early in the disease course, malaria and Ebola virus disease can look similar. Now, in standard protocols in outbreak settings for Ebola virus disease are treatment with empiric oral antimalarials, or antimalarials in general. And now the critical question of this study is trying to figure out what are the clinical and patient-centered evidence for empiric antimalarials. Now, the data from the study comes from 5 Ebola treatment units that were within the 2013 and 2016 Ebola virus disease outbreak. And at these 5 sites, some 2,500 patients were treated and 478 had confirmed Ebola virus disease. Now, just looking quickly at the figure to the left, these are the 3 main countries that were impacted by the 2013 to 2016 outbreak. These were Guinea, Sierra Leone, and Liberia. Also shown in this map are the number of cases in each of these locations up to April 10th of 2016. Now, the study design, there were standardized guidelines at each of these Ebola treatment unit sites, and they're standardized across all the sites. And patients only received or did not receive oral antimalarials based on the availability of resources and not based on any other factors. And data was taken with all of the medications that were given throughout the treatment course of the patients. And Ebola testing was carried out using real-time reverse transcription polymerase chain reaction assays. And we used logistic regression models to determine the impact on mortality or the association with mortality of oral antimalarials to generate adjusted odds ratios based on controlling for as many factors as possible, or as many factors as seem to be important in creating this model. Now, variable selections for this model were taken both from bivariate analysis to determine confounding and based on previous literature that's shown associations with mortality in Ebola virus disease. And these were for multivitamin treatment, for cefixime, and signs of symptoms of bleeding, diarrhea, dyspnea, and dysphagia. And then also age was included in this. And then we did a sensitivity analysis to determine the robustness of the results. Here's a study flow diagram. So 478 patients had Ebola virus disease, but only 424 patients were used in the study because data was missing, sufficient data was missing for 48 of these patients, and 6 patients were deceased on arrival. Now, in terms of the clinical characteristics of note, for the malaria rapid diagnostic tests, they're carried out in 243 of the 424 patients, or about 57.3%. And 48 or 19.8% of these had a positive result. So there's a significant disease burden for malaria in this population at baseline of those that were coming into the Ebola treatment units. And early oral antimalarials were given in the first 48 hours of care, were provided in 376 of the cases, or 88.7. This is a bar chart showing the mortality in all locations on the left, and then Liberia and Sierra Leone. There's not a statistically significant difference among each of these categories. Overall, 77.1% of those that did not receive oral antimalarials in the first 48 hours died. 55.1% of the of those that did receive oral antimalarials in the first 48 hours died. Now, of course, there's confounding here because in more resource-limited settings, there were other resources that were also lacking with the oral antimalarials. And then looking at the logistic regression model, there was still significant association with reduced mortality in providing when oral antimalarials were provided, and the adjusted odds ratio is 0.34 with a statistically significant confidence interval at 95%. The sensitivity analysis in the patients with a negative malaria rapid diagnostic test, there was no statistically significant association for mortality in patients, but of note, there was a protective effect with the point estimate, and this indicates that further research really needs to be done. Now, overall, there